I'm not quite sure what this is doing in a session in a tutorial on physiology, but it is the topic I've been assigned, and I'm going to address it. And with apologies to Neil, I'm going to talk about mortality. So to compare imaging and physiology, let's talk about something unambiguous and basic. Let's not talk about composite endpoints. Let's talk about mortality. So if we look at all-cause mortality in FAME1, there is no difference between FFR-guided and angiography-guided PCI at 1 year, 2 years, or 5 years. And if we now transition to FAME2, this is the 1-year mortality data, no difference between PCI plus medical therapy versus medical therapy alone, that is FFR-guided. No difference at 2 years, and the curves out to 5 years are effectively superimposable. And if we look at some meta-analysis data using individual patient data from patients with stable lesions enrolled in FAME2, DYNAMI-3 pre-multi, and compare acute, you can see that FFR-guided PCI versus medical therapy has no difference in cardiac death. And Ripcord 2, which was presented at ESC last year, angiography versus angiography plus FFR, the mortality numbers are virtually identical. And this is some interesting data from Asan Medical Center, where they looked at a large registry of over 6,000 patients, and they broke it down into FFR less than 0.7, 0.71 to 0.75, 0.76 to 8, 0.81 to 0.85, 0.86 to 9, and greater than 9, and looking at the predictor of cardiac mortality according to the severity of FFR, there is no difference, just a trend for an impact once you get up to a very high FFRs. And finally, define FLAIR and IFR Sweetheart, all-cause mortality in the FFR and IFR groups are the same. So, as Neil mentioned earlier today, physiology-guided PCI does not improve mortality. What about intravascular imaging? Well, there the story is very different. This is a meta-analysis of 10 randomized trials in which IVUS-guided PCI was associated with a lower incidence of cardiac mortality. And if we now look at the two largest studies, the 1,400 patient IVUS XPL and the 1,448 patient ultimate trials, and we took the patient level data and we created one giant database, and we had 3-year follow-up in both studies, and you can see that with IVUS guidance, there's a 50% reduction in mortality after IVUS-guided stent implantation. And if you achieve optimal PCI or optimal IVUS criteria for stent implantation, the annual mortality is somewhere about 0.2% or lower. We don't have as much data with OCT. The only real data of any significance is opinion, and there was no difference in IVUS or in IVUS and OCT in terms of cardiac mortality. Now let's look at some lesion subsets. Let's talk about left main disease. In terms of deciding whether or not to treat a left main lesion, this meta-analysis from Javier Esquinet's group compared FFR more than 0.8 mostly, and an IVUS MLA more than 6 square millimeters mostly, and at 30 months of follow-up, the mortality was identical in the FFR and the IVUS-guided groups. And in terms of IVUS-guided left main stenting, all-cause mortality and cardiac mortality are markedly reduced. And in fact, if you were in last talk where the data from BSIS was presented, as shown in this slide, there's a nationwide 34% reduction in mortality when left main stenting is IVUS guided, and the operators with the greatest left main PCI volumes not only had better overall outcomes, but a greater impact of IVUS guidance. up to a 60% mortality benefit. What about acute coronary syndrome, STEMI and non-STEMI? Again, back to physiology. There's no difference in mortality comparing an FFR-guided strategy with an angiographic-guided strategy. And in the complete trial, comparing culprit lesion, PCI, versus complete revascularization, angiographically guided, of course, complete revascularization had better mortality or composite of death and MI. I believe Niels is going to talk about flower MI, but you can see that the mortality was identical in the FFR-guided group and the angiographic-guided group. This is a strategy for non-culprit lesions in STEMI patients. And a meta-analysis of FFR-guided complete versus culprit-only lesion revascularization, again, shows no mortality for physiologic guidance. What about imaging? We have several large online registries. I'll share with you two of them from Korea. This is the KAMIR registry, in which there was a reduction in patient-oriented cardiac events and device-oriented cardiac events because of reduction in all-cause mortality and cardiac mortality with imaging guidance, whether IVUS or OCT. And now in the updated KAMIR National Institute of Health registry, you can see that cardiac mortality is reduced by 50% when primary PCI is IVUS guided compared to angiographic guided. And we also have a meta-analysis in acute myocardial infarction showing a reduction in all-cause mortality of 30%, combining STEMI and non-STEMI, and looking only at STEMI patients, a reduction in all-cause mortality of 21%. And these are huge databases. So the question is, why does intravascular ultrasound or imaging in general reduce mortality? And I think we've become a little bit blasé and a little bit unattentive to the impact of stent thrombosis, restenosis, and its treatment. These are a series of studies looking at the mortality after a patient presents with stent thrombosis and is treated, and another series of patients if a patient presents with in-stent restenosis and is treated. And if I just call out two studies, this is a left main study where the 5-year mortality after left main stent, in-stent restenosis was 6% per year. And this is the CATH PCI registry in the United States, where the 4-year mortality of in-stent restenosis was 7% per year. So these are not benign events. These events have horrible consequences. And we can easily understand how imaging guidance reduces stent thrombosis, TLR, and TVR in this meta-analysis combining randomized and non-randomized trials, meta-analyses combining only randomized trials, and look in the reduction in TVR and stent thrombosis, averaging somewhere in the 50% range. And back to our old friend left main disease, a reduction in stent thrombosis and TLR and TVR of more than 50%. Well, if you prevent stent thrombosis and in-stent restenosis early, then it's no surprise that the impact of imaging guidance is even greater at 3 years than it was at 1 year, because you prevent the event early in the first year, and that has a long-term effect on terms of mortality, as I have showed you. So the conventional wisdom is to use physiology to decide whether or not to treat a lesion, particularly in a non-left main location. In left main locations, I think you can use imaging or physiology, and then use imaging to optimize PCI once a decision has been made to treat the lesion. That's conventional wisdom, and quite frankly, that's what I actually believe, and that's what we practice in New York. However, in patients undergoing PCI, intravascular imaging, IVUS and probably OCT-guided stent implantation reduces mortality in almost every clinical scenario. That is not seen with physiology. FFR and the various non-hyperemic pressure ratios do not reduce mortality, whether in stable patients, culprit lesions in patients with STEMI, or non-culprit lesions in patients with STEMI. And what is more important than reducing mortality? Thank you for your attention.